topic, I missed the word MSS. So I was so very happy that using checkpoints, yeah, okay, maybe I should be able to make the slides. But then when I saw the slide, when I was preparing this thing, the MSS came in. And then it's difficult because the evidence and data is not very great. So the presentation would be what are the options in metastatic CRC, molecular classification and impact on the immunotherapy treatment, the factors and reasons for poor response in the MSS subtype, and then are there any therapeutic options to overcome this, and then we'll look at slides on pole mutation and TMB, and then we'll conclude the group. So over the period of time, the immune checkpoints in metastatic CRC is mainly for the MSI high subgroup, and you have the anti-PD-1, PD-L1, CTLA therapy available, and then probably the rest of it is in the combination therapy, is mainly in the MSS subtype, which most of us do not discuss. The MSI is only 10% of the patients and 90% of them are still MSS. So this topic has been given to look at whether immunotherapy is working in MSS group. There has been an heterogeneity in the colorectal cancers, and we can see that there have been multiple different types of classifications based on the type of the immunoscore, the immune infiltration, whether the MSI is high or MSI is low. And then you have a molecular subtype where you divide them into 4 groups. Again, mainly the molecular subgroup is driven by the immunoscores. And then we have the again immune mechanisms, looking at the different classifications in the CRC. Now the pembrolizumab in MSI high got approved based on the phase 2 study. There were 90 patients of colorectal in that study, and we can see that only 36% of the patients actually responded to the immunotherapy. So when looking back, why there was only 32% and why some of these patients did not respond, the main reason was one was the misdiagnosis of MSI status in some few patients. So whether IHC is good enough to make a classification, or should we do an IHC and a PCR. There was tumor heterogeneity. 10% of these patients had pseudoprogression. Some of them had the FAS apoptosis pathway decreased, which led to the immune evasion and the HLA class 1 defects. So the first and the most important reason was the misdiagnosis of MSI status, hence making it more clear that MSS patients probably will not respond to immune checkpoint inhibitors. Now we should understand the difference between an MSI and an MSS. We can see that the MSI have more tumor mutational burden, they have more frame shift mutations, they have more immunogenic peptides, and the immunoscores are very high when compared to the MSS, where they are mainly chromosomal instability and they have a very low immune score. So all matters is the tumor environment, and that's what makes it responsive or unresponsive to immune checkpoints. Now we have 4 molecular subtypes: the CMS1, CMS2, CMS3 and CMS4, and we know that the CMS2 and CMS3 are literally do not have T cells, and the TMEs are bad, so the immune they are more like an immune desert when compared to the MS1 and MS4. Now what we understand by cold tumors and hot tumors is that you can see in a desert kind of thing where actually there are no CD4 T cells, and then you have some CD4 T cells but they don't infiltrate well, they also do not respond very well to immunotherapy, and then you have these T cells which completely infiltrate into the tumor and they are hot and respond well to immunotherapy. So is there any method by which these cold tumors can be converted to hot tumors? By adding additional probably chemotherapy agents, or by targeted therapy, radiotherapy, or using the epigenetic mechanism. we could convert some of these cold tumors into hot tumors. So again, why CMS2 and CMS3 do not respond? The main reason is that there is a lack of tumor immunogenicity in this, and the low immune cell infiltration. Now the mechanisms, again, to reiterate that cold tumors and the hot tumors the cold tumors can be converted into hot tumors by different mechanisms, and these are mainly the chemotherapy and molecular targeted therapy, the role of radiotherapy, and the role of some of the oncolytic virus. Now this is a very busy slide, but we can see that there are many trials going on, which makes it very clear that the MSS is not a very easy group to actually treat with immunotherapy and ongoing studies. So I'll just show a brief few examples of how people have looked at. One is role of chemotherapy. This was a trial where patients who had received immunocheckpoints inhibitor as phase 1 study, and then the patient progressed, and these patients were taken up for subsequent chemotherapy to see if patients post immune therapy responded to chemotherapy better. So there were 67 patients, of which MSS was 44 patients, and on disease progression, not everyone received the chemotherapy. 29 patients received chemotherapy, and of which 25 patients were MSS. The chemotherapy varied from anywhere including the standard FOLFOX regime with or without targeted regime. They also used some of the VEGF TKIs like the regorafenib, and 4 patients, which is 19%, achieved partial response, and 43% of the patients achieved stable disease with a disease control rate of 62%. So telling us that that post MSI, probably if you are giving chemotherapy, there could be some responses. This was just the survival curves. Not very impressive, but these are multiply treated third line, fourth line set of patients. There was one more group of scientists who looked at VEGF, and they looked at in MSS there seems to be increased levels of VEGF, and this gave an idea that we could target probably the MSS tumors with anti-VEGF plus an immune checkpoint inhibitor. And this is the study which looked at capecitabine with bevacizumab with or without atezolizumab. And in this group, they had taken 133 patients and randomized, of which 90% of these patients were MSS. Not very impressive, but again, there seems to be some responses in some patients. But the most interesting part of this study was a subset analysis which they looked at, and said that if patients who did not have a liver metastasis versus patients who had liver metastasis, the OS seems to be slightly better in patients who received this group with patients who did not have liver metastasis, which implies that probably liver metastasis patients do not do very well with the immunotherapy. Now about the targeted therapy, people looked at combining targeted therapy with immune checkpoint inhibitors, atezolizumab with or without cobimetinib versus regorafenib, and we could see that actually there was no difference in the 3 subsets where regorafenib actually did as good as atezolizumab plus. It was a negative study. The curves are bang on this. And subsequently, people again tried looking at regorafenib with different combinations. Regorafenib with nivolumab. There seems to be a mixed responses in all these studies, with some having up to 33% overall response rates to down to no response. And then people looked at what could be the reasons why some few patients responded with immune checkpoint inhibitors, where some of them did not. And one of the studies, which was the Rego-Nivo study by the Japanese group, looked at responses, and they actually found that the overall response rates were quite high when compared to just using regorafenib. And the reasons again for these could be, again, the liver metastasis again and again is coming out as an important prognostic or predictive marker, which responds very poorly to immunotherapy. And patients in Rego-Nivo study, patient who had liver metastasis, the response rates are only 8.3% compared to 50% in patients with lung metastasis. And two retrospective studies again recently demonstrated that liver metastasis correlated with a shorter PFS and OS. And when they looked at the multivariate analysis, I think one of the strongest point was liver metastasis, and probably the trial should look at including a different subset of patients, probably avoid using including patients with liver metastasis. Role of radiotherapy. Radiotherapy again promotes tumor cell death, releases tumor associated antigen and MHC complexes, which results in T cell recruitment and activation, and also the inflammatory cytokines. Now there are two single arm phase 2 studies. One actually did not meet the pre-specified endpoint with a very poor overall response rates. The other phase 2 study, again, marginal improvement in overall response rates of 12.5%. But what people are looking at is that the dose and fractionation employed plays a very important part, and this is something which is ongoing and needs to be looked at. Oncolytic virus, this seems to be very interesting phenomena where you could use virus to enter into the tumor tissue, get endosized, and after that release the tumor associated antigens, and this tumor associated antigens could actually make the hot tumor cold tumor into a hot tumor. The last two slides on the pole mutations, very interesting. It forms 1% of the colorectal cancers seen in young patients, right-sided tumors, mutually exclusive with MSI. They have very high tumor mutational burden, and they are enriched with mutation associated antigens, and they have remarkable response to pembrolizumab. So this is one small subset of MSS which could actually benefit from immune checkpoint inhibitors. The second is the MSS colorectal with elevated TMB. This was a study which looked at two groups. The blue ones are the category 1, and the red ones are the category 2. And you could actually see the MSS CRC as a part of the category 1, which means that there is a good correlation of the neoantigenicity with CD8 T cell infiltration, which means that if you have a MSS CRC with a high TMB, they probably will do very well with the immune checkpoint inhibitors. Again, the point is there is only 3% of these patients who will actually have a TMB very, very high. So we have 3% here and 1% poor, so probably 4% of the MSS probably will respond to immune checkpoint inhibitors. So again, to sum up, a lot of treatment options are there, but none of them seem to be very promising, at least till currently. So take home message, tumor intrinsic variations due to TMB status is different between the MSS and MSI CRC. So obviously MSS patients are not going to respond very well to immunotherapy. Liver metastasis seems to be one of the ones which seems to be quite resistant to immunotherapy, and pole mutations and high TMB, which form only 4% of the subgroups of MS-CRC, might respond to ICI, and novel immunotherapy strategies are being looked at, but that's only for the future. So the bottom line is, at present, it's very dismal in MSS. Thank you.